Welcome to ePathshala on classes on social medicine and community health. And today we are going to discuss, we have been discussing healthcare delivery system. And to continue, now last time we switched to primary health care. And this time we are going to deal with the actual institution which takes care of the primary health care, that is the primary health center, its organizations and functions. A word of thanks to the guidance of Professor C.P. Mishra and his team from Aligarh Muslim University. Thank you. In the learning objectives, we have 4 objectives, and we learn at the end of the lesson we would be able to know what is the background and the introduction of primary health centers, what is the service delivery pattern at the primary health center level, the minimum requirement of the service delivery at the primary health center, and the Indian public health standards for maintaining a primary health center, and last of all, functions of the primary health center in different areas and programs. Now, what is the concept of the primary health center? See, way back in 1946, the Bohr Committee gave a concept of the primary health center as a basic health unit. This Bohr Committee was the one which instituted a area. They said that if we divide the whole area into smaller bits, which would be more approachable and we could look after it. So this concept of primary health center was made, and integrated curative and preventive health care to the rural population with emphasis on preventive and promotive aspects of healthcare. The Bohr Committee aimed at having a health center to serve a population of 10,000 to 20,000 with 6 medical officers and 6 public health nurses and other supporting staff. The Mudaliar Committee, which came in 1962, so the program was started, and with the hitches, it started running. So a mid-course correction was done in 1962 by the Mudaliar Committee, which recommended that the existing primary health centers should be strengthened and the population to be served by them to be scaled down to 40,000. Now, in the primary health center, they had to have an approach also. So, in 1978, we just finished discussing the declaration of the Alma Ata Conference in 1978 proclaimed primary health care and set the goal for health for all by 2000. A new philosophy of equity, equitable distribution, equal services for health services for all, and a new approach, the primary health care approach, was given. The National Health Program Plan in 1983 proposed reorganization of the primary health centers on the basis of one primary health center for every 30,000 rural population in the plain and one PHC for every 20,000 population in the hilly, tribal or the backward areas for more effective coverage. As on March 2014, 25,020 primary health centers have been established throughout the country. In order to provide optimal level of quality health care, a set of standards are being recommended from primary health centers to be called the Indian Public Health Standards for the primary health centers, because we need our own health standards. They may not. The question is that setup in the primary health centers may vary from place to place. So we have to regularize the Indian Public Health Standards to meet the requirements of all these primary health centers throughout the states and throughout the country. The launching of National Rural Health Mission has provided this particular opportunity, and the standards prescribed in this document are for a primary health center covering 20,000 to 30,000 populations with a 6-bed. Setting standards is a totally dynamic process. The overall objective of the Indian Public Health Standard for a PHC is to provide health care that is quality oriented and sensitive to the needs of the community. So that means it must be quality, it must provide quality, we cannot provide less than what is required, and it must be acceptable to the community at large. Now, the minimum requirements for the delivery of services. The following requirements are being projected based on the basis of 40 patients per doctor per day. Of course, normally it could be 40 patients in a primary health center, and the figure could vary as per the season wise and as per situation wise. Now, 60% of the utilization of available indoor and observation beds, out of the 6 beds, at least 60% utilization should be there, of which 2 are kept mostly for maternal uses, that is for delivery services. And as regards manpower, 1 more medical officer may be from Ayush or a lady doctor. That is, like we said, if the medical today's medical requirements must go hand in hand with the traditional medicine, and that is why this particular doctor is now being placed at the primary health center to meet the requirements of the people. To the existing total staff strength of 15 in the PHC to make it a 24/7 services delivery center. Now, the Indian Public Health Standards for primary health centers are expected to be as follows. The Central Council of Health, at its first meeting held in January 1953, had recommended the establishment of primary health centers. Now, PHCs are actually not spared from the issues such as inability to perform up to the expectation due to non-availability of doctors at the PHCs, which is the most common excuse. And even if post-out doctors do not stay at the primary health center headquarters, inadequate physical infrastructure and facilities and insufficient quantities of drugs. Now, these are actually the basic excuses which are normally faced in day to day from the primary health center. Doctors posted do not go there, patients are drawn away from there, inadequate physical structure is there, they say the fan is not working or whatever it is, then there are no drugs and insufficient quantities of drugs are there. So none of these rules will now hold good, and there is definitely a lack of accountability to the public and the lack of community participation, with a lack of set standards for monitoring quality care. So all these have now to be seen to in order to provide optimal levels of quality health care, which is a set of standards are being recommended for primary health center to be called the Indian Public Health Standards for primary health centers. In other words, now these will become the landmark measurement standards for each and every primary health center to be maintained. So the objectives of IPHS for primary health centers are: 1. To provide comprehensive primary health care to the community through the primary health centers. That means primary health care which is acceptable, equitable, approachable, affordable to every single member of the community, and to achieve and maintain an acceptable standard of quality of care, to make the services more responsive and sensitive to the needs of the community. So, therefore, the minimum requirement at the PHC for meeting the IPHS standards are: to the needs of the community. So, therefore, the minimum requirement at the PHC for meeting the IPH standards are the medical care, OPD services, 4 hours in the morning, 2 hours in the afternoon, and in the evening. Minimum OPD attendance should be at least 40 patients per doctor per day. So that means the doctor has to be good, he has to be comfortable and he has to see the patient. 24 hours emergency services should be there, appropriate management of injuries and accidents, first aid. The simpler accidents and the simpler injuries and accidents would be able to look after, otherwise the rest would be referred to the higher centers. Stabilization of the condition of a patient before referral, dog bites, snake bites, scorpion bites and other emergency conditions. Then the referral services have to be streamlined. And of course, we have the inpatient service, which is the 6 beds. So immediate emergency admission can be done before they are referred to the higher centers. Now, in maternal and child health care, including family planning, antenatal care is most important. So, under antenatal care, early registration of all pregnancies, ideally in the first trimester, minimum of 3 antenatal checkups is essential, associated services of iron and folic acid distribution, injections of tetanus toxoid, a minimum of 3 for the pregnant lady, and if she comes within 2 years of the first pregnancy, a minimum of 2 injections is a must. Minimum laboratory investigations like hemoglobin, urine for albumin and sugar to find out that she might not be toxemic, and RPR test for syphilis. Nutrition and health counseling they are very important factors, and identification of high-risk pregnancies and their appropriate management. What is high-risk pregnancy? High-risk pregnancy are those women who complain of high blood pressures or even borderline blood pressures. They have edema on either single or both the feet, and edema which disappears at rest. So this could be nutritional edemas, or it could be edema because of the toxemia of pregnancy. And once you examine the urine, there could be protein in the urine. So all these, a combination of all these, or even 1 or 2 factors, could be that the woman, and there could be low hemoglobin. So she could be approaching, or maybe her previous child was a cesarean section and it was a high risk case. So these high risk pregnancies have to be screened out in time so that appropriate management can be given to these. And chemoprophylaxis for malaria in high malaria endemic zones, as per the national malaria program guidelines, have to be given. And first of all, most important, referral to first referral units and other hospitals in case an emergency arises or there is a high risk pregnancy. They must be referred to the other hospitals in time. So this is basically becomes a first screening set in the line of medical services in the rural areas. Now, intranatal services. Delivery services have to be managed, and since there are beds associated, beds provided in the primary health center, so therefore you have 2 beds for round the clock deliveries, and others may be taken as and when needed. So a promotion of institutional deliveries is a must. Conducting of normal deliveries is a must. Assisted vaginal deliveries, including forceps and vacuum delivery whenever required, and if and when the doctor is available to do it comfortably. And of course, the manual removal of placenta should be done, and it should be seen that the placenta is complete in all respects, and should see for calcification spots in the placenta, and appropriate and prompt referral for cases needing specialist care, management of pregnancy-induced hypertension, including referrals, pre-referral management, that is obstetric first aid, and in obstetric emergencies that need expert assistance. So either they could be managed there, or they must be immediately referred to the first referral units and be sent to the community hospitals. Now, in the postnatal care, a minimum of 2 postpartum home visits have to be made within the first 48 hours of delivery. The second should come within the 7 days through the subsector staff. Initiation of early breastfeeding within half an hour of birth must be done. So, in case she has delivered either at home or in the primary health center, immediate early breastfeeding should be instituted. Education on nutrition, hygiene, contraception, and prevention of infection during the postnatal period. Essential newborn care as per the guidelines of the Government of India on essential newborn care, and others, that is the provision of facilities under the Janani Suraksha Yojana. These are a must and they should be carried out in toto within the framework of the primary health center. Newborn facilities, for whatever is possible, care of the neonatal resuscitation definitely should be taken care of, because we have the oxygen cylinders and we have the care for the newborn baby, and most important, management for neonatal hypothermia and jaundice. If it cannot be managed, at least it should be recognized, diagnosed, and immediately sent to the first referral unit for immediate care of the child. Now, in the care of the child, emergency care of the sick children under 5 or even younger children who are coming, which includes integrated management of neonatal and childhood illnesses, care of the routine childhood illness, and essential newborn care is a must. So, if a mother has delivered at home, she may be brought to the center in order to be taught how to look after the newborn, especially if the weight of the child is on the borderline. It may not be, it may be just 2 kg or just below 2.5 kg. So, in that case, essential full care must be taken. And promotion of exclusive breastfeeding for 6 months. Most important, I must mention here that health education should be constantly given during the antenatal period, that the moment the child is born, they should not feed the child any other drops of, for example, there are a habit of giving goat's milk or cow's milk drops or honey through a cotton stick or a swab or even with a dirty spoon. None of these habits should be followed because they are completely contraindicated. So, it is only exclusive breast. The child should be put to the breast within half an hour and breastfed very comfortably. Full immunization of all infants and children against vaccine preventable diseases as per the guidelines of the Government of India. Vitamin A prophylaxis to the children, again as per the guidelines, and prevention and control of childhood diseases and infections. Vitamin A to prevent blindness in children, because blindness, that is the nutritional blindness, because many people, there are many communities where certain food habits are followed. Vitamin A is not given in sufficient quantities, leading to night blindness. So, as such, if cases of night blindness are being reported, immediate vitamin A prophylaxis and treatment should be given to prevent, control, and make it normal. Prevention and control of childhood diseases and infections like cough and acute respiratory infections, diarrheas, should be taken care of. Now, family planning. Family planning is a subject which we just cannot leave out at all from our health services. They form the basis and the knitting bond between all the services. You make the family complete, you make the family happy, they will follow all rules and regulations. So, therefore, education, motivation, and counseling to adopt appropriate family planning methods, particularly with special regards to either condoms or to oral contraceptive tablets or to intrauterine contraceptive devices or to men using condoms. Provision of contraceptives such as condoms, oral pills, emergency contraceptives, IUD insertions. We must have these procedures which can be done immediately. Methods, permanent methods like tubal ligation and vasectomy could be done and should be advised also in the right cases. Follow-up services to the eligible couples adopting permanent methods, tubectomy, vasectomy, very, very important, especially in cases. See, tubectomy has to be done only when we are absolutely sure that no period has been missed in a woman. So that is one sign that she has not become pregnant. Secondly, for vasectomy cases, we must take care to teach the person that sperms could be alive up to 6 weeks in the vast difference even after a vasectomy. So, in any case, if they have to have family life, they must take care to use condoms and to prevent an accidental pregnancy occurring, and from that accidental pregnancy occurring after vasectomy leading to issues of social issues and questions being raised as to the pregnancy. So therefore these important factors are very, very important, and appropriate counseling and referral for safe abortion services must also be given in case it is needed. Counseling and appropriate referral for couples having infertility. Cannot forget the infertile couples. So that is absolutely essential. Following family planning, we come to the services of medical terms, MTPs, using manual vacuum aspiration technique, which is a very easy technique, but it should be carried out only within a period of 8 weeks. Management of the reproductive tract infections, sexually transmitted infections, and health education must be completely given. Along with it, nutritional services must be given so that we are looking after the total health in its entirety. Most important, diagnosis and management of anemia with vitamin A deficiency must be seen to, and we must do this in coordination with the ICDS. And for the children, the school health, regular checkups, appropriate treatment, see for diseases which could appear, that is worm infestations, vitamin A deficiencies, or weight, insufficient weight at a not coordinating with the height and the growth of the child. So these will point to nutritional deficiencies, and these children must be picked up and seen in the regular clinics. Adolescent healthcare, lifestyle education, promotion of safe drinking water, basic sanitation, prevention of locally endemic diseases like malaria, kala-azar, Japanese encephalitis, disease surveillance, control. These are all parts and parcels of the care which has to be given at the village level. Then most important, promotion of sanitation, using of toilets and appropriate garbage disposal is absolutely essential. Then collection and reporting of vital status events. Cannot forget the registration of birth and deaths. So that is an important event, and that has to go into the municipal record. And of course, education about health and behavioral change. So these early changes must be noted and must be treated as soon as possible. National health programs, including reproductive and child health programs, HIV, AIDS control programs, non-communicable disease control programs, and of course, let us not forget the gamut of infective disease, that is tuberculosis, leprosy, malaria. All these have to be seen to at the local levels, and all cases have to be reported as soon as possible to the medical officers at the primary health center in case they might be starting on an epidemic. So control of epidemic as per the national guidelines is also essential. Now, I was talking about disease surveillance. Disease surveillance is important because primary health center will collect and analyze the data from the sub-center and will report information to the district surveillance unit. Appropriate preparedness and first level action in outbreak situations. Laboratory services for diagnosis of malaria, tuberculosis, typhoid with the rapid diagnostic kits, and detection of fecal contamination of water with a rapid test kit and chlorination levels in case we start a diarrhea epidemic. Then national control of blindness. I just mentioned few points about this, about the treatment and diagnosis of common eye diseases. And in case it is necessary, refraction services for at the school level or at the adolescent level or at the senior citizen level, very essential. Then, of course, for the senior citizens, detection of cataract cases and referrals for cataract surgery. Then, under the National Program for Control of Blindness, we have the basic services should be there, that is for diagnosis and treatment of common eye infections, refraction services, detection of cataract and referral for cataract surgery. Then you have the national vector-borne diseases, in which you must look out for cases of malaria, microscopic confirmation should be there, suspected Japanese encephalitis, dengue, and immediately symptomatic treatment, hospitalization as per protocol should be followed immediately. Of course, in areas which is where Kala Azar is endemic zones, Kala Azar should be looked for. Then where filaria is endemic, we should look for the microfilaria cases and for the swelling of the foot and the fevers. Most important in today's context, we cannot forget the National AIDS Control Program. IEC information, education and communication activities to enhance awareness and preventive measures about the STIs and the HIVs and prevention of parents to child transmission, organizing of school health education programs, screening of persons practicing high risk behavior, and risk screening of antenatal mothers with one rapid test for HIV, and to establish referral linkages. Linkage with the microscopic center for HIV/TB coordination, and condom protection and condom distribution is a must. So therefore, we guide and we help patients with HIV or AIDS for receiving ART. Now, in the referral services, since this is a basic unit, we need to have appropriate referral services for referring to the higher centers. And in case anybody needs specialist care, or we need to stabilize a patient, or we need appropriate support for patient during a transport, or providing transport facilities either by the PHC vehicle or by the other available referral transport. So these are very important and provisions should be made for that. Then training, inbuilt training, even during working within every 6 months is absolutely essential, because training supplies practice, training supplies knowledge, training supplies better workers and hence better service. So health workers and traditional birth attendants, initial and periodic training of paramedical staff, and most important, training of ASHAs at the field level. And why not periodic training of doctors also? This may be done at the district levels. Training of ANMs and LHDs in antenatal and skilled birth attendants should be done either at the primary health center, or they may be sent to the community health centers, or they may even be referred to the district hospitals for a training session. Essential laboratory services, which include the routine urine, the stool and the blood tests, bleeding time, clotting, VTCT, diagnosis of RTI, STDs with the wet mounting, sputum examination for tuberculosis is absolutely essential. Blood smear examination for either malarial parasite or for filaria, rapid test for pregnancy, and the test for syphilis, yaws, test for typhoid, and most important, test for fecal contamination of water, counting of the E. coli, so that if water is contaminated, and that too particularly the drinking source of water, immediate action has to be taken in order to purify and to clear that water. And estimation of chlorine levels of water using the different reagents and the different tests. So then we come to monitoring after all of practice and service. Monitoring and supervision of services are absolutely essential, and they are they will include monitoring and supervision of activities of the sub-center through regular meetings and periodic meetings, periodic visits, monitoring of all the national health program, because it is national health programs have to filter down right from the center to the peripheral levels. Monitoring activities of ASHA, who is a peripheral worker, should be done, and MOs should visit all sub-centers at least once a month. Health assistants, male and female, the lady health visitors, should visit sub-centers at least once a week. Then rehabilitation. For rehabilitation, disability prevention, early detection, intervention and referral is absolutely important. In case there is a fracture, in case they have polio, they have recovered. So disability prevention is most important, and early detection of all these, intervention and referral to the proper hospital is absolutely essential. The primary health centers would provide 24-hour delivery services and newborn care all 7 days a week. Selected surgical procedures such as vasectomy, tubectomy, including laparoscopic tubectomy, medical termination of pregnancy, hydrocelectomy and cataract surgeries as a camp could be done as a camp or through a fixed day approach. Then recording of vital events, most important, recording and reporting of vital statistics including births and deaths. Then maintenance of all relevant records concerning the services which are provided through the primary health center. Most important, the transport service must be kept in perfect order, because referral can come at any point of time. So the PHC should have an ambulance for transportation of emergency patients, and referral transport may be outsourced. If it is not an emergency situation, certain taxis or cars could be hired and they could be paid for their services. Transport for supervisory and other outreach services should be there. Now, the staffing pattern of any primary health center would be manned by a medical officer. First, recommended is 3, along with the addition of an Ayush practitioner who joins as the 4th medical officer, and there should be an accounts manager. It's recommended, although we don't have in many centers. Then we have a pharmacist and nurse midwife, the health educators or the health assistant, male and female, the lady health visitors, laboratory technicians, the driver should be there, and the class was. So total existing will be 15, although recommended could be more staff to equip the centers, up to 24 to 25 people. Then most important, whatever services have to be given, there must be quality assurance. And in quality assurance, periodic skill development, training of the staff. The mid-course correction always demands quality assurance and quality training of all the staff in all categories in their various jobs, and these should be given to them. A few aspects that need attention are interaction and information exchange with a client or a patient, and attitudes of the healthcare provider is most important. If a healthcare provider is rude and doesn't look a very happy person, the patients are often they don't like it, and they would prefer to go to an outside sourced medical care provider, which would probably cost them. So therefore, attitude of healthcare providers needs to undergo a radical change so as to incorporate the feeling that the client is most important and needs to be treated with respect. Cleanliness should be maintained at all points. Last of all, monitoring. This is important to ensure that quality is maintained and also to make changes if necessary. Internal mechanism, record maintenance, checking, of course, these have to be maintained, and monitoring through the PRI or the village health committees or through the Rogi Kalyan Committee. So facility surveys should be done again and again on the primary health centers according to face the fact that we are maintaining the Indian public health standards, and to have baseline information so that we can improve on them at every point of time. And most important, accountability of every single person. Every single worker is accountable for his or her reactions, and the Charter of Patients' Rights should be made available in every PHC. Every PHC should have a Rogi Kalyan Samiti or a primary health center's management committee for improvement of the management and service provisions of the primary health center in order to give primary health care to each and every patient or to each and every individual of this country. To summarize, the organization of the primary health center consists of a medical officer in charge, along with the other staff, which provides basic preventive, promotive, curative services such as MCH services, adolescent, various national health programs are run, safe drinking water, hygiene, along with health education, IEC, and activities to improve the health conditions of the population have to be maintained. And with this, thank you for visiting ePathshala.